Hello. We'll go ahead and get started this evening. Thank you all for joining us. So my name is Sana Masood, and I am the head of the Medical Center Archives here at New York Presbyterian Weill Cornell. I want to thank you all for joining us today in person and online for this evening's lecture with Dr. Johanna Schoen. We welcome participation from all attendees during the question and answer session following the lecture. For attendees online, there is a Q&A box on the bottom of your screen where you can enter a question. We will get to as many questions as possible after the lecture. Closed captioning is also available, and you can find the option at the bottom of your screen to turn it on or off. The Heberden Society is a history of medicine lecture series that has been held at Weill Cornell Medical Center since 1975, and I would like to thank the Office of the Dean for continuing to support the series. Go to the next. I also want to share our upcoming lecture this spring with Dr. Carolyn Eastman, presenting on the front lines of New York City's yellow fever epidemics on April 8th at 5 p.m. Please note there is a change in location usually from the room we do it in person, and it will also be hybrid and available online. So all Heberden lectures are hybrid, free, and open to the public, so we are always happy to have you all join us. Okay. And then, if you are interested in the history of New York Presbyterian Weill Cornell Medical Center, I invite you to visit the Medical Center Archives. The archives includes material dating back to 1771, including this photo from the 1950s with the aftermath of snowfall in front of the medical center, and we hope that the upcoming storm does not make a similar incident happen. You can find more than 14,000 digitized photographs and documents online through our website, and the link is up on the screen. And we have even more material available for in-person research, and I'm happy to help with any planning and coordinating of research visits. And you can reach out to the archives at the email that's also noted on the screen. I would now like to introduce Arlene Shaner, who will say a few words about the New York Academy of Medicine, the co-sponsor of tonight's lecture. Welcome, Arlene.
And how do I advance the slide here?
Is it just this? Yeah. It's like a little finicky.
There we go. So I'm so happy to say that the New York Academy of Medicine co-sponsors one of the Heberden Society lectures every year. For those of you who are not familiar to us, at NIM, we focus on addressing health in every phase of life to build the health span, ensuring that all people have what they need for not only longer, but also healthier lives. This means starting with birth justice and going all the way through the end of life. The New York Academy of Medicine is now 178 years old. And I just want to advance to the next slide. And we have had a library since the very beginning of our existence. That library has been open to the public since 1878 and is the only medical library here in New York that is open to anyone who wishes to use it. You do have to make an appointment to come and visit, but we do have a very significant collection of history of medicine and public health materials in the library, an extraordinary collection. And we welcome researchers, and we welcome all kinds of other visitors, and we do have lots of digital collections, events, newsletters, virtual visits online. You can find us by going to nim.org/library and then looking for the links to all of these things. Thank you.
All right, well now it is my pleasure to introduce Dr. Johanna Schoen. Today she will be presenting her lecture, Glasnost and Perestroika in the NICU, Clinical Care and Parent Activism in the History of Neonatal Intensive Care. Dr. Schoen grew up in Hamburg, Germany, where she went to college and studied history with a minor in economics. She received her PhD from the University of North Carolina, Chapel Hill. Currently, she is a professor of history at Rutgers University, New Brunswick. Dr. Schoen's interests include history of medicine, history of reproductive rights, and the history of sexuality. Dr. Schoen has written 2 books, Choice and Coercion, Birth Control, Sterilization, and Abortion in Public Health and Welfare, and Abortion After Roe, which won the William H. Welch Medal by the American Association for the History of Medicine for the best book in the history of medicine. Additionally, she edited the anthology Abortion Care as Moral Work, Ethical Considerations of Maternal and Fetal Bodies. For the past decades, she has worked with abortion providers to preserve the history of legal abortion in the United States and to use historical analysis and insights to help preserve access to abortion care. Dr. Schoen is currently working on her next book, Life and Death in the Nursery, A History of NICUs. With that, I would like to please welcome Dr. Schoen.
Thank you so much for the lovely introduction, and thank you also for the invitation and for coming out on this evening to listen to a story that is not as happy as that face that was reflected there, but that is as it is. I will preface this, and also actually I want to say thank you to all of those. I can't see you, but we'll Zoom. I will preface this by saying that some of the language that I'm using in this talk is today considered inappropriate or offensive, but I'm using it to be in sync with the language that was used back then. And also some of the details of the talk might be a little bit hard to listen to, so I apologize in advance for this. On the 27th of June, hold on. Okay, on the 27th of June in 1992, a group of parents, neonatologists, nurses, and social workers met in Burlington, Vermont to discuss the state of neonatology. Over the course of 2 days, they deliberated on a list of 10 principles that parents whose children had been patients in neonatal intensive care units had developed to address concerns with the medical care their infants had received. Parents' complaints were wide-ranging. They accused neonatologists of disenfranchising and overruling them if the neonatologists disagreed with parents' wishes regarding the medical treatment premature infants should and should not receive. They charged neonatologists with trying to manipulate parents by offering vague or outright deceptive information when discussing infants' prognosis, withholding information about serious medical problems babies developed in the course of their NICU stay, and concealing the fact that many of the treatments were experimental in nature. And they accused neonatologists with child abuse when clinicians failed to administer pain control during routine medical procedures as well as during major surgeries. The Burlington Conference was the brainchild of NICU parent turned health advocate Helen Harrison and neonatologist Gerald Lucy. Harrison had earned a degree in Slavic languages from UC Berkeley and worked as a Russian to English translator and as a medical and laboratory technician with the Berkeley Community Health Project when in 1975 she gave birth to her son Edward. 3 months premature and suffering from listeriosis, a serious bacterial infection, Edward was not expected to live. When physicians took him off the respirator to allow him to die, however, Edward defied all expectations and continued to breathe. At that point, the NICU staff jumped into action and vigorously supported Edward, who survived with multiple disabilities, including hydrocephalus and severe intellectual disabilities. While Harrison had initially a positive view of the NICU, this changed in the late 1970s and early 1980s when she began to interview parents about their experience with neonatal intensive care units to write a guidebook for parents who experienced the birth of a critically ill premature infant. In retrospect, Harrison noted, I see many ways my interest in Russia helped prepare me for the NICU. It gave me a familiarity with totalitarian regimes, pain and suffering, mystifying languages, big lies, and the need for Glasnost and Perestroika. In 1983, she published the Premature Baby Book and became one of the co-founders of Parent Care, an international support organization for parents of high-risk infants. Harrison met Lucy in the mid-1980s when she sent him a letter to the editor for publication in the journal Pediatrics expressing concerns about the aggressive treatment of very low birth weight infants. Then chief editor of the journal, Lucy took note. Harrison began to forward him letters she had received from other NICU parents. Ultimately, their joint attempt to offer concerned parents a forum to articulate their criticism led to the organization of the Burlington Conference. Gerald Lucy, a member of the first generation of neonatologists in the US, graduated in 1952 from NYU's College of Medicine. Over the following years, he interned at Bellevue Hospital's Children's Medical Services and did his residency at Babies Hospital, part of Columbia Presbyterian Medical Center in New York City. There, he trained with Bill Silverman, one of the founders of neonatology and an early voice for ethical care in the field. After a research fellowship at Boston Children's Hospital and Harvard Medical School, Lucy joined the University of Vermont College of Medicine in 1956. He spent his career advocating for the practice of evidence-based medicine in neonatology, and as chief editor of Pediatrics, offered NICU parents a forum to voice their concerns. Starting in the post-World War II years, the country began to direct its attention and considerable resources to medical issues considered of national importance, among them the high infant mortality rate. As clinicians began to use new and untested treatments and medical technologies to try to keep premature babies alive, however, results were often catastrophic. In the 1940s and 50s, it became increasingly fashionable, for instance, to give large amounts of oxygen to preemies who, as a result of their immature lungs, had developed respiratory distress syndrome. This had led to an epidemic of infant blindness. It wasn't until 1954 that the results of a national cooperative study among 18 hospitals indicated that the cause of blindness was too much oxygen. Clinicians knew how to take care of premature babies who were relatively well, but didn't know how to treat severely ill newborns. Assessing the state of newborn care in the late 1950s, pediatricians realized that they were failing critically ill newborns and began to look towards the establishment of intensive care nurseries to care for premature and extremely sick babies. In 1960, Yale opened the first neonatal intensive care unit in the country. Carefully planned to incorporate the latest design, the new Yale New Haven Special Care Nursery was a marvel and model of modern medicine, offering, I had to cut him out in terms of time. He is actually the founder of the Neonatal Intensive Care Unit at Yale, Louis Gluck, who also trained with Bill Silverman, but I really meant to go to this slide that shows the Yale New Haven Special Care Nursery as the marvel and model of modern medicine that it was, offering sick infants and their parents a dazzling array of new technologies in one space. It featured one large and three smaller rooms built around a central nursing station. To increase efficiency, the design team placed the 40 isolates only 20 feet apart from each other and installed all the equipment for each isolate in the ceiling above. Flexible tubes for oxygen, compressed air, suction, and multiple electrical outlets hung down from the ceiling, allowing nurses and physicians to instantaneously attach respirators, monitoring devices, and infusion pumps to the infants below. In addition, clinicians had access to a variety of standard and cardiopulmonary monitoring and resuscitation instruments, including a volume-controlled respirator, a portable unit to determine blood gases, cardiac monitors, apnea alarms, as well as an open-air radiant heater grip, which permitted clinicians to perform procedures without worrying that infants would develop hypothermia. Windowless, the unit was located in the middle of the building. The overhead lighting and the constant hum and beeping of the medical equipment made the space loud, noisy, and bright. It reminded me of the movie Coma, one of the nurses remembered. The bodies were all suspended and they were maintained by machines. The Yale New Haven Special Care Nursery emerged alongside NICUs in other medical centers in the US. In Nashville, neonatologist Mildred Stahlman established a neonatal intensive care unit at the Vanderbilt University Medical Center in 1961. Funding from the National Institute for Health to study respiratory distress syndrome allowed Stahlman to equip the new facility. In other medical centers, too, physicians began to experiment with the idea of neonatal intensive care units. Hospitals in London, Toronto, Montreal, Stanford, Boston, the University of Pennsylvania, the University of California at San Francisco, and Johns Hopkins University all established NICUs in the early 1960s. With the establishment of NICUs, the treatment of premature and critically ill newborns changed from a philosophy of handling the infants as little as possible to one of aggressive treatment. The establishment of clinical centers devoted to the care of premature and sick infants increased the number of infant patients, as well as the clinical problems with which infants presented. But the ability to now treat severely ill infants for whom treatment had not been available earlier also led to disagreements between physicians or between physicians and parents over appropriate treatment options. This was especially the case in situations where clinicians and parents were unexpectedly confronted with a child with congenital anomalies, such as infants born with trisomy 21, Down syndrome, with duodenal atresia and intestinal obstruction, or infants born with myelomeningocele, the most common and most severe form of spina bifida, a congenital nervous system defect. The establishment of NICUs and special care nurseries allowed clinicians for the first time to systematically address the surgical needs of these infants and, in the course of the next 2 decades, change the clinical understanding of what could and should be done for them. Since a third of infants with duodenal atresia have trisomy 21, the classic textbooks, The Surgery of Infancy and Childhood, had advised surgeons in the 1950s to carefully evaluate all infants with duodenal atresia and to forego corrective surgery if infants showed signs of trisomy 21. Similarly, before the 1950s, the prognosis for infants with myelomeningocele, which involves varying degrees of leg paralysis and bladder and bowel impairment, was poor. Approximately 80% of children with MMC have hydrocephalus, which can result in cognitive impairment and blindness. Most died in the first few months of life of meningitis or as a result of hydrocephalus. Because of the complex medical needs of these infants, as well as the social stigma and isolation of giving birth to a child with a severe disability, children with MMC or trisomy 21 were until the 1950s frequently raised in institutions. Indeed, considering the outcomes for these infants extremely poor, clinicians regularly advised parents that infants with trisomy 21 and duodenal atresia, as well as infants with myelomeningocele, be left to die. But 3 things changed in the 1960s. First, the growth of clinical genetics in the 1950s and 60s led to an understanding of genetic diseases, and in the 1970s and 80s, screening tools, including the use of ultrasound, amniocentesis, and eventually chorionic villi sampling, that allowed for the detection of these conditions during pregnancy, and with the legalization of abortion and expansion of abortion procedures, gave women the opportunity to end the pregnancy in case of a positive test result. Second, a number of exposés in the 1960s highlighted terrible conditions in mental institutions and residential schools, leading activists to lobby for deinstitutionalization. After the Kennedy administration in 1963 elevated mental retardation to a federal health policy issue, the federal government adopted an approach to reduce institutional populations and offer community support. Parents, too, began to voice concerns about institutionalization, and some began to establish advocacy groups that moved children with disabilities into the mainstream. Third, advances in therapies and refinement of surgical techniques contributed to the survival and higher functioning of infants with spina bifida and other health problems. By the early 1960s, the development of antibiotics to treat meningitis and of shunts to alleviate hydrocephalus allowed physicians to aggressively treat infants with MMC. And as the 1960s progressed, clinicians' attitudes for infants with trisomy 21 also began to shift. By the early 1960s, the surgical correction of duodenal atresia was well established. Moreover, major changes in the clinical care of premature infants in the 1960s meant that clinicians could now keep their patients alive. The provision of assisted ventilation for continuous respiratory support in the mid-1960s and the development and administration of surfactant to premature infants to treat respiratory distress syndrome revolutionized the field of neonatal medicine, while the introduction of IV feeding and the development of microinfusion pumps allowed for the feeding of extremely preterm infants, and by the end of the decade, high-caloric IV preparations were better able to meet their nutritional needs. These changes notwithstanding, many parents continue to be wary of raising a child with severe disabilities. Faced with caring for a severely disabled and/or intellectually impaired child, families confronted significant caregiving burdens and expenses. They struggled with social shame and isolation at a time when raising a disabled child at home was still an intensely private experience. As one neonatologist remembered, parents dreaded having retarded children. When in 1963, pediatricians at Johns Hopkins University encountered an infant born prematurely with trisomy 21 and duodenal atresia, a debate about the treatment of the infant ensued. Worried about the impact that a child with severe disabilities would have on their family, including the 3- and 5-year-old siblings at home, the parents refused to sign permission for the surgery that would have corrected the duodenal atresia. The infant died 6 days later. By the early 1970s, medical files at Johns Hopkins University suggested that the 1963 infant had not been alone. Other infants born with trisomy 21 and duodenal atresia too had been left untreated and had died. Indeed, it is likely that this happened in hospitals around the country. When in 1971, Robert E. Cook, pediatrician-in-chief and chairman of the Department of Pediatrics, learned of another infant with trisomy 21 and duodenal atresia, whose parents had decided against surgery, he tried unsuccessfully to intervene. The infant died after 13 days. Dissatisfied with his faculty, some of whom had supported the parents' decision, Cook turned to the Joseph P. Kennedy Jr. Foundation, which was preparing an international symposium on human rights, retardation, and research, and suggested the creation of a brief documentary dramatizing the 1963 and 1971 cases to screen at the opening of the symposium. The resulting film, Who Shall Survive? One of the Choices on Our Conscience, premiered in October of 1971. You can find it on YouTube if you want to watch it. Against the backdrop of debates over the legalization of abortion, changing protocols regarding brain death, and the beginning of bioethics. Over 9 minutes and 15 seconds, it traces the delivery of baby Doe, his diagnosis with trisomy 21 and duodenal atresia, the parents' decision not to consent to surgery, the sign on his crib indicating that he should receive nothing by mouth, and the wait until his death in the documentary 15 days later. The film highlighted the moral distress of the staff as the baby slowly starved to death. One could not come away from watching the film without the impression that what had happened here was wrong. More than any case up to that time, Who Shall Survive brought the issues of end-of-life decisions involving infants with disabilities out of the back rooms of the hospital and to international attention. Over the course of the 1970s, clinicians debated the ethics of non-treatment and the clinical details surrounding these decisions. In a 1973 article published in the New England Journal of Medicine, 2 pediatricians at the Yale New Haven Special Care Nursery articulated their concern with the increasing number of severely disabled infants who now survived due to advancements in neonatology. In hospitals with infant intensive care units, they noted neonatal mortality rates had fallen by over half the past decade compared to hospitals without such units. But while some survivors of these units were healthy, others continued to suffer. Severely handicapped by a myriad of congenital malformation that in previous times would have resulted in early death, the authors wrote, the new treatment options raised increasing concern about the quality of life for these severely impaired survivors and their families. Some clinicians bemoaned the emotional suffering and chronic grief that attended the birth and survival of what was labeled a deformed, retarded child, and urged careful evaluation to identify hopeless, burdensome cases before initiating expensive and life-prolonging treatment. The emotional and physical pain that we cause child patients to suffer, they concluded, must be justifiable in terms of some reasonable hope for a future happy social adjustment. But clinicians lacked a unified understanding of the meaning of future happy social adjustment. While some sought to ensure that infants would be able to become productive citizens, others warned against such utilitarian views. The experience of Peggy and Robert Stinson well illustrates the suffering and chronic grief that could accompany neonatal care in the 1970s. On December 17, 1976, Peggy Stinson gave birth to their son Andrew at a community hospital in Bethlehem, Pennsylvania. At 800 grams and a gestational age of 24 weeks, Andrew was not expected to survive. Peggy and Robert asked the medical staff at Community Hospital that no heroic efforts be made to extend his life. Against their wishes, hospital staff transferred Andrew a week after his birth to the NICU at Children's Hospital in Philadelphia, a tertiary care hospital where he was placed on a respirator. Over the next 5 months, following on the heels of the Karen Quinlan case, he became, in the words of his parents, hopelessly entrapped in an intensive care unit where the machinery was more sophisticated than the code of law and ethics governing its use. He remained dependent on the respirator until he was finally allowed to die 5 months later. As a result of the treatments he was receiving, trying to keep him alive, Andrew developed a range of complications. Placed on the respirator, he developed bronchopulmonary dysplasia, neonatal chronic lung disease, as well as retrolental fibroplasia, an eye disease frequently leading to blindness. The chronic lung problems, in turn, led to a slowing of Andrew's heart and a lack of oxygen in his blood. Unable to meet his nutritional needs, in particular his need for minerals, he suffered multiple bone fractures. As Andrew's lungs became irreparably diseased, he developed high blood pressure and began to have seizures. When on June 10th, Andrew dislodged the tube connecting him to the respirator, CHOP's physicians decided not to reconnect him. He finally died on June 14, 1977. As his parents sarcastically noted, he was in effect saved by the respirator to die 5 long, painful, and expensive months later of the respirator's side effects. Devastated and furious, Peggy and Robert Stinson wrote a letter to CHOP's administrators and personnel, sharply criticizing the aggressive treatment of Andrew. The story of Andrew's short, cruel, institutionalized life, they warned, is a case study in the limits and excesses of modern medicine. In 1979, they published a book, The Long Dying of Baby Andrew, about the ordeal. And in addition, they published an abridged version of their letter to the hospital in Atlantic Monthly and in 1981 in the Journal of Medical Ethics. Andrew Stinson's case was far from exceptional. Parents across the country found that neonatologists ignored their wishes to allow their severely ill infants to die, instead resorting to coercion, threats, and court orders to treat the infants, only to have them die months or even years after gruesome medical ordeals. The Stinsons' complaints were followed a couple years later by similar charges from California couple Sue and John West, who in 1980 gave birth to their son Brian. Brian was diagnosed with trisomy 21, a missing esophagus, and a heart murmur. The attending physician described how the particular combination of Brian's defects were far more serious than either one would have been alone. His missing esophagus could be surgically reconstructed, but Brian would never be able to swallow normally and would be constantly in danger of choking on his food. Since trisomy 21 was associated with poor muscle tone, this further increased Brian's chances of choking. In addition, stomach acids would back up into his reconstructed esophagus, and since children with trisomy 21 are also overly susceptible to upper respiratory infections, without a properly functioning esophagus to drain normal secretions to the stomach, these fluids could back up enter the lungs and cause pneumonia. Finally, physical therapists warned that the reduced mental capacity of children with trisomy 21 might defeat the therapeutic process required to learn how to use the new esophagus, and that Brian's frequent hospitalizations and surgical interventions would mean that attempts at early intervention and stimulation, so crucial for children with trisomy 21, would be frustrated, indeed, might significantly send Brian back. Doubting that the long-range outcome for Brian would be good, the Wests refused to authorize the surgical repair of Brian's esophagus. The decision, John West remembers, was based on love and on the golden rule. Had they been in Brian's place, neither he nor his wife would have wanted to be kept alive. The hospital's doctors and administrators, however, disagreed with the West's refusal to consent to Brian's surgery and asked the state to bring charges under the state's child abuse laws against the Wests. The Wests were charged with willful neglect, and Brian was removed from their custody and placed under the guardianship of the state. Susan West recalled, "We watched helplessly as our baby endured multiple surgeries and a host of chronic, painful maladies. Brian spent the initial months of his life attached to a nasal suction machine and was fed by a host through a hole in his stomach. Infections became chronic. Reconstructive surgery on the esophagus was performed in 2 stages when he was a little over a year old. The process can only be described as hell for him." And I have to add to that Susan West told me that the surgeon who performed the surgery had never done a surgery like that before, and basically did it because she thought it was really interesting to try to do it. The wounds, the process can only be described as hell for him. The wounds failed to heal properly. Stomach acid backed up continuously, causing such pain and irritation that it became necessary to restrain the baby's hands and feet by tying them to the 4 corners of the crib. His new esophagus was never functional, and he became caught in a perpetual pilgrimage from nursing home to hospital and back again. Shortly after his 2nd birthday, in October of 1982, another infection of unknown origin sent him to the hospital once again. While there, he went into respiratory shock and was placed unconscious on a respirator. When he stabilized, he was severely brain damaged, blind, bleeding internally, experiencing intermittent kidney failure, and had an overwhelming infection throughout his body. On December 21, 1982, at 26 months of age and weighing only 14 pounds, Brian James West finally died. 5 days later, John and Susan West appeared on CBS's 60 Minutes to talk about their experience. Neonatologists' willingness to consider parents' request against the aggressive care declined further in the early 1980s after President Ronald Reagan, prompted by outcries of his right to life constituents, passed so-called baby dough regulations, which threatened hospitals with the loss of federal funds if they withheld medical treatment or nourishment from handicapped newborns. To facilitate whistleblower reports of alleged violations, the administration established a toll-free 24-hour handicapped infant hotline with a number prominently displayed in delivery rooms and pediatric wards. 2 years later, the regulations were added as an amendment to the Child Abuse and Neglect Prevention and Treatment Act, which made withholding medical treatment a reportable act of neglect and abuse. The regulations not only pressured neonatologists to resuscitate infants even if the outlook for their survival and quality of life seemed low, passed at the same time as a Reagan administration gag order prohibiting healthcare providers at facilities receiving federal funds to advise patients about abortion. They left couples with no information about the few choices that they might have had. And the baby dough regulations further encouraged intimidated healthcare providers to aggressively treat even the sickest infants. By the end of the 1980s, neonatologists routinely treated infants whose chances of survival was low and who were likely to end up with significant disabilities and health problems for years to come. An analysis of 1,765 very low birth weight, this is the wrong slide, I'm sorry. Here we go. 1,765 very low birth weight infants delivered between November 1987 and October 1988 at 7 NICUs illustrate the outcome. Less then a quarter of premature infants born at 23 weeks gestation survived to discharge from the NICU. At 24 weeks gestation, survival rates to NICU discharge climbed to 1/3 of all infants treated, and by 25 weeks gestation, the survival rate reached 54%. Premature infants fared worse the lower their birth weight. Only 1/3 of infants with a birth weight below 751 grams survived to NICU discharge, and only 15% were free of major complications such as chronic lung disease, necrotizing enterocolitis, and grade 3 or 4 intraventricular hemorrhage. Survival rates reached 2/3 with a birth weight between 751 and 1,000 grams, and 93% for infants born with a birth weight between 1,251 to 1,500 grams. The analysis also revealed important variations between NICUs, as well as differences in the philosophy of care and definition and prevalence of morbidity. Depending on the NICU, survival rates for infants below 751 grams, for instance, ranged from 20 to 55%. 2 centers provided assisted ventilation to practically every infant, whereas in some of the medical centers, some extremely immature infants, those below 751 grams, were not treated at all. Emerging alongside parents' rights movements of the 1970s and activism on behalf of HIV/AIDS patients, parents protested the conditions under which their infants were being treated. When, in the mid-1980s, Jill Lawson learned that her premature son Jeffrey had been awake throughout major surgery at Children's Hospital National Medical Center in Washington, D.C., the anesthesiologist had paralyzed Jeffrey with Pavulin, a curare drug that left him unable to move but totally conscious, Lawson raised alarm. Together with Helen Harrison, Lawson protested this practice in letters to the editor of Birth. 10 years ago, Harrison wrote in her letter to the editor, "Our prematurely born son Edward was shunted for hydrocephalus while paralyzed with curare. Although he could not move, cry, or react in any way, he could see, hear, and feel as large incisions were cut in his scalp, neck, and abdomen, as a hole was drilled in his skull, as a tube was inserted into the center of his brain, then pushed down under the skin of his neck, chest, and abdomen, and implanted deep in his abdominal cavity." At a 1985 National Conference of Parents of Premature and High-Risk Infants, mothers and fathers discussed a wide range of painful medical procedures their children had been subjected to: major surgery, chest tube insertions, cut-downs, all performed without painkillers, gangrene and amputation from infiltrated IVs, bones broken during chest physiotherapy, skin pulled off with adhesive tape, and burns from the monitors. Added to that were the 24-hour-a-day bombardment with bright light and loud noise, and numerous iatrogenic afflictions from improperly evaluated therapies. If this were going on in any other setting, one mother exclaimed, it would be called torture. I have long wondered how an infant can differentiate between pain or abuse that is medically necessary and abuse at the hands of an out-of-control parent or caretaker, another noted. It is generally acknowledged that abused infants become emotionally scarred. No one says they will be fine because they can't remember, yet the myth remains that the NICU veterans forget. And indeed, parents argued that their children did not forget. Moreover, for many NICU graduates, the NICU was only the beginning of years of medical treatments they had to endure. Infants who had received shunts for hydrocephalus, for instance, could face many surgeries for shunt revisions as they outgrew their shunts or as the shunts became infected. By the time of the Burlington Conference, 16 years of age, Edward had endured 13 surgeries, including 7 in the past 2 years. Many children experience these procedures as painful and traumatic. As one mother reported about her 8-year-old son, whom she tried to talk about his shunt, he keeps saying that it's too scary. He doesn't want to hear about it. And every time she took him to the doctor, he, like Edward Harrison, shook and trembled, and it took him days to get over it. Given these realities, it is no surprise that families complained of being stripped of their parental rights in the NICU, only to be handed many months later a severely impaired baby whose overwhelming problems were now to be the parents' responsibility. Bob and Sarah Thorson, whose triplets were born in 1987 at 27 weeks gestation, recalled that when their sons were born, it was made very clear to us that in no way were we going to be part of the decision-making process for our sons. We were hoping and assuming that we would have some information and ability to help with decision-making regarding the boys, but that was immediately taken away. Neonatologists also intentionally offered misleading information and withheld crucial information about infants' conditions. Wanda Boggs, a Milwaukee mother who gave birth to twins at 24-week gestation, was not told about her son's devastating intraventricular hemorrhage until a week after it occurred, and only learned about it after she and her husband began to ask pointed questions. When we asked about the consequences of such a severe bleed, Boggs recalled, we were told that our son might have problems in math later on. Meanwhile, a neurologist was writing in the chart that a likely outcome was a persistent vegetative state. Researchers analyzing the relationship between parents and NICU staff acknowledged that the information parents received often consisted of euphemisms and half-truths. Dr. Carol Rodman, who studied decision-making for infants below 1,000 grams, noted that at resuscitation, treatment planning and withdrawal of treatment, three crucial junctures of moral decisions, parents were either not invited at all to participate in decision-making or influenced in their choices by misleading information. Neonatologists and pediatric surgeons, for their part, often became caught up in the excitement of addressing clinical problems in the present while losing sight of the fact that parents worried about the long-term future. Doctors worried that infants were too fragile to tolerate anesthesia. Others believed that preemies did not feel pain. Some surgeons were unaware that they were operating on an infant without anesthesia. Finally, especially after the passage of the baby doll legislation, the discussion over treatment of severely ill neonates became distorted by pro-life politics. Many neonatologists began to practice defensive medicine. Others tied their support for aggressive treatment to their own pro-life beliefs. Clinicians shied away from an open discussion about the suffering infants might endure as a result of treatment, foreclosing a consideration whether allowing an infant to die might be more humane than attempting or continuing treatment. Instead, they trivialized and oversimplified the medical problems of infants and refused to acknowledge the broad range of functionality and further health complication infants and their families might face in the future. Parents also criticized the lack of long-term outcome studies that left neonatologists unable to predict whether infants would recover relatively normal or spend their lives with severe disabilities. Most follow-up studies of NICU graduates ceased when the child was 2 or 3 years of age. This time period, parents argued, was too brief to predict with some accuracy what the quality of life for premature infants might be. At age 3, we thought our son Edward might be a genius, Alfred Harrison pointed out. He could count to 100, he could read, he could distinguish a trapezoid from an octagon. Many people, including medical and developmental experts, told us this kid is advanced. It wasn't until he was 5 or 6 years old that we knew he was actually severely retarded. And we know from talking to many other parents that some important disabilities don't show up until school age or beyond. If we are going to weigh the pain to gain ratio in this whole process and put these kids and parents through medical ordeals that can last for years, we ought to have a pretty good idea what it's going to mean in the long term. But following NICU graduates longer, neonatologists argued, was prohibitively expensive, since it was difficult to keep track of families through moves and family changes. In addition, clinicians felt that the rapid therapeutic changes in neonatology would mean that outcome studies would be clinically useless, as they reflected the stage of clinical practice at the time a child had been a NICU patient rather than at the time of follow-up. Indeed, it was not just long-term outcome studies that were missing in neonatology. Following the pattern of the 1940s and 50s, when clinicians used new and untested treatments and medical technologies to try to keep premature babies alive, therapeutic interventions in neonatology continued to be long on experimentation and short on rigorous studies of safety and efficacy. Many methods of treatment have been introduced following reports of their effectiveness on limited numbers of infants, and in many instances without controlled clinical trials, the National Institute for Child Health and Human Development found in 1985. It appears that the practice of neonatal medicine remains in part an art rather than an exact science. The lack of research was a particular point of contention at the Burlington Conference. By 1992, when attendees convened at the University of Vermont, the licensing of surfactant, a chemical compound that supported the breathing of infants with underdeveloped lungs, significantly increased the survival of even smaller premature babies. Surfactant was responsible for the biggest drop in infant mortality, showing its most significant effect in infants born with a birth rate below 1,000 grams. But parents and some of the neonatologists questioned the cost of trying to save ever smaller infants. Parents framed the need for accurate information, appropriate pain control, and the ability to influence how aggressive the medical care of their premature infants ought to be as an overriding ethical issue in neonatal care. Given that the benefits of many of the interventions and therapies their infants received were unknown, parents urged neonatologists to inform them about debates in the field and to make research regarding pain control in infants their priority. Helen Harrison implored neonatologists at the Burlington Conference to acknowledge pain control as the ethical issues parents understood it to be. If physicians feel they can't give premature babies safe and effective pain relief for surgery or for severe chronic pain, then the pain these babies suffer becomes an ethical issue that should be specifically discussed with the parents, she noted, and expressed her frustration that after years of advocacy and protest, pain control in the NICU continued to be an issue. And a father urged, if you are going to put a small infant on a ventilator, at least tell the parents there is some controversy out there, that there is a question whether treatment is worthwhile under 1,200 grams or 800 grams or whatever the limit is today. The 10 principles discussed at the Burlington Conference asked for parents' greater involvement in clinical decision-making and improved neonatal care for the infant patients. Neonatal care, the principles urged, should be family-centered and based on open and honest communication between parents and professionals. Parents should receive all the facts concerning their infants' medical conditions to allow them to participate in truly informed decision-making, including information about uncertainties, as well as information from parents whose children have been in similar medical situations. In any medical situation involving very high mortality and morbidity, great suffering and/or significant medical controversy, parents should have the right to make decisions regarding aggressive treatment for their infants. But parents also wanted earlier education about the ways that pregnancy might go wrong. Expectant parents, the principles noted, should be offered information about adverse pregnancy outcomes and be given the opportunity to state in advance their treatment preferences if their baby is born extremely prematurely and/or critically ill. The guidelines also implored neonatologists to acknowledge and alleviate the pain of infants, ensure an appropriate environment for babies in the NICU, as well as the safety and efficacy of neonatal treatments. Finally, the principles pushed for greater collaboration between parents and professionals to promote meaningful long-term follow-up for all high-risk NICU survivors and acknowledged that critically ill newborns can be harmed by overtreatment as well as by undertreatment. We must work together, the principles concluded, to insist that our laws and treatment policy be based on compassion, to promote awareness of the needs of NICU survivors with disabilities, to ensure adequate support for them and their families, and to decrease disability through universal prenatal care. While the Burlington Conference was an important step in the crafting of the 10 principles, which Harrison published in a pediatrics article the following year, Harrison noted in the end that the conference was not all sweetness and light. Significant disagreements remained, both about the importance of pain control for premature babies and about the use of birth weight or similar criteria to define areas in which parents should be able to have a voice in treatment choices. The disputes pitted one group of doctors on the side of parents, while another group remained critical of the principles. Indeed, Harrison reported that one of the neonatologists in attendance remained adamantly opposed to defining any areas in which parents can make treatment decisions. Several other physicians were also reluctant to give over this power in any but the most extreme situations. Still, a majority of the medical professionals at the conference seemed to favor a genuine role for parents in treatment decisions, and some called for an entire rethinking of the methods and goals of neonatology. While the Burlington Conference and Harrison's subsequent pediatrics article are indicative of the fact that parents were able to garner the ear and support of some neonatologists, reform of NICUs and the implementation of the principles took another decade, and implementation remained uneven. It took until the early 21st century for many NICUs to move to new quarters that facilitated greater privacy, both for clinical discussions and for mothers to nurse their infants and parents to practice kangaroo care, skin-to-skin contact with their infants. The physical transition of clinical space coincided with a more meaningful move to family-centered care and a recognition of the distress that NICU parents experienced. By the early 2000s, NICUs began to establish psychological support services for parents as well as formal neonatal palliative care programs. These services, too, however, were unevenly distributed, since in many hospitals, the employment of support staff has been hampered by a lack of financial resources. Harrison was always careful to acknowledge the support of medical professionals. Writing the principles and the development of the pediatrics article, she told audiences after Burlington, was in itself the result of an unprecedented effort in parent-professional collaboration that lasted nearly 1.5 years and involved the input of parents, physicians, nurses, social workers, attorneys, and ethicists. But her call for Glasnost and Perestroika also reminds us of the very political nature of this fight. Echoing the assessment of several clinicians of the field of neonatology, Harrison called parents to action. There is a growing tone of sober reevaluation, a sense that neonatology has backed itself into some difficult ethical and medical corners and might benefit from informed public and parental input. Just as Peggy and Robert Stinson, John and Sue West, and Joe Lawson had made their grievances public and by doing so contributed to the emergence of a fledgling parent advocacy movement, Harrison reminded her audiences that parents needed to speak out and raise a fuss. Glasnost and Perestroika required more than mutual support and information exchange. And in her first Burlington speeches, she offered examples of parents who had begun to take matters into their own hands. Unable to get the neonatologist at one NICU to agree to take their severely ill infant off life support, they had contacted an ethicist and neonatologist at a neighboring hospital who agreed to the transfer of the infant and the plan to withdraw life support, leading the uncooperative neonatologist to change his mind. One father had disconnected their infant from a ventilator, and a woman with a 24 to 25-week pregnancy and ruptured membranes had called from Mount Sinai Hospital in New York, where she had been admitted to find out where she might get a late abortion and then discharge herself to get said abortion rather than put her premature infant and herself through a C-section and NICU ordeal. In a country where pro-life politics led to deep political divisions in any discussion involving fetuses and newborns, parents had to be willing to stand up for their own and their premature infants' behalf. Thank you. Can you negotiate if there's Zoom
The
questions? Yeah.
Okay.
Just step over here. I don't think I need a microphone too.
Okay.
I will take comments and questions.
Hey, that was very interesting. My name is Jeff Bowman. I've been a neonatologist in the U.S. since 1979.
Awesome. I'm going to ask you to interview. Not now, but in the future. No, I do. I need all the questions I can get.
In St. Louis, Washington University, 1989, at a time where the baby blood regulations came out.
Yeah.
And for anybody over there, 24 hotline was a real thing. So if there was a nurse who didn't like what you were doing, she could call Washington and do that in the home. So that was very real, and that changed the complexity of how babies were being treated, because doctors were scared.
Yeah.
That some nurse or some parent or something would do that. I then went to Parkland Hospital, where I was for 15 years. And then I came to Neonatal for 20 years. So what you said is true, although I would say use simple examples to generalize. So this family was Stinson's.
Yeah, they are extreme examples.
Those are extreme examples. I will add that you Heberden Allison very well.
You did?
And I brought you here as a visiting professor.
Yeah.
Because I thought she would be good for folks to hear about things. And I remember telling her that she's true Heberden Allison style going over attention. I said, come, you look into a thing and you see cockpit over it. You tell the pilot, all right, this is how we should do things, etc. And she just laughed.
Yeah.
She was an advocate that I think didn't want any discussion of the position. She wanted to push herself, and only her viewpoint really went.
Yeah.
I knew Jerry Lucy very well over the years.
Yeah.
And he became a strong advocate for it.
Yeah.
Neonatology has changed. And today, we're talking about 750 and less. People are talking now down to 400 grams. I don't agree with that, but that's where we're at. In 1988, there was a paper that came out, is survival possible for less than 800 grams.
Yeah.
Today, we go up to 23 weekends and 22 weekends. I'm not saying that's right.
Right.
So you can have an abortion at 23 weeks, but you can also say, I want to have my child. Now, you're 100% correct about pain. Pain was something that was, I couldn't understand. I remember just a great surgeon. I said, Jesse, you've got this special pain.
Yeah.
They don't feel anything. I said, you can take this baby, drop it into the pain. And it took a while for that to come through.
Yeah.
That part was very correct. So neonatology went through phases.
Yeah.
Mentions of acting and that reduced mortality rate. So,
Yeah, and I have to say that my sense also is that the baby door regulations were not only not loved by neonatologists because they didn't like the 800 number, but also because they disagreed. Many of them disagreed, and I think what it did, it forced the field to develop different ethical standards in order to try to figure out what do we actually want, right? So in a way, it drove the development of considerations about how to make decisions and where to involve parents in ways that might not have happened without the baby door regulations. That is at least my sense, talking to people and reading the literature.
and then there was, as you said, involvement of the families.
Yeah.
That varied from region to region.
Yeah. Yeah.
So
From
Baylor
clinician to
Hospital
clinician too,
in
probably.
Houston, it really didn't get parents any opportunity to speak.
Yeah.
Despite, in fact, case, I'm not sure whether it was Houston or Milwaukee, the father pulled the ventilator, disconnected.
Yeah, there was a big court case about it. I think
It was in Milwaukee, but he went to trial.
Yeah.
And they, for doing that.
Yeah.
Today, in our intensive care unit, there is a baby who's not brain dead but 40 years old. Parents want everything, but the baby doesn't move. The baby's got a tracheostomy, the baby's got a GT, and the baby's going to a rehab center.
Yeah.
Okay, the baby will do nothing. So
And the
now
parents are hoping for a
pendulum
miracle, I
has
assume.
has moved to the other extreme.
Yeah.
So you spoke about trisomy 21, and I remember that.
Yeah.
William Hydesfield.
Yeah.
But that by the 80s had resolved, and those babies were being treated. In this particular auditorium, we had the ethics committee of this institution. We had a baby with trisomy 18, which is pretty lethal in the sense that most die early, but even if we do survive, you have significant neurodevelopmental advances. And it was my philosophy that I was going to subject a baby to a trait called cardiac surgery with that. And this mother came and said, I want this all done in my baby. And I said, here's a division, and turned it down, find another hospital. We were asked you to do it, or something. And the ethics committee gave us such a hard time on this particular issue. Eventually, they said, if you as a group agree to this, we will say that the mother needs to go out swimming. You know, we would support the baby, provide counter care. So it's a very complicated issue. It's that very important for parents in certain instances where you're doing too much to have that input. But we've gone overboard now, so that we've got a baby who's probably dead, is going to have a great duty to the absence.
Yeah, and I think that what also really changes the investment of parents in the hopes for premature deaths of this assisted reproductive technology, right? So at some point they invest a lot of money to become pregnant, and then they want these babies.
Yeah, I don't want to criticize, but that Harrison father whose kid could count to 103 and you're an octagon, well, whatever, you tell me severely retarded. Unless this kid was autistic, which can develop. I do not buy that for a particular second. Between 3 and 6, something must have happened, meningitis or abuse or something. But if you count to 103 and you can read, it is. That's advanced as the talk. So something must have happened between 3 and 5 to say he was severely retarded.
My assumption was, but I might be wrong, is that the problem mostly was that he doesn't have any executive functioning. So he's actually still alive. I haven't talked to Harris's widower personally, but we've emailed. He was actually the one pointing his wife's papers with her CSF.
And that baby may, you don't go at 3 years, counting to 100.
Yeah.
I mean, I have followed hundreds of babies through 18 years, 20 years, and you can tell a lot at 18 months. You're correct to pick up some of these exact problems. It takes a bit longer. The only reason I say that is because people see that story and say, oh, you're going to have this long term. Ideally, yes.
Yeah.
But I'll add another complexity. Our great governments, not only the current government, but previous, they want you to do everything, but they don't support all of that. And so we see the difference. If you've got private insurance, we can see these babies recover. Something called brain plasticity. Those who don't get that, they're flattened. So the importance of what we call early childhood intervention is very critical. That's very expensive. So that there are very few states that support that program. Neonatology is very expensive. Expensive financially, emotionally, you name it. But post-neonatal care is even more expensive. The follow-up that goes, the speech therapy, the occupational therapy, feeding therapy, very complicated issue. So I think when you talk about perestroika and take it a bit further, because I think the circle has gone back through where I think families are demanding more.
Yeah.
We want you to resuscitate our baby at 23 weeks. It's up to me, I would say no. You know, I would say, let's see what the baby does. we want you to do everything for you. And that's 20, 25, down to lower. And so, yeah, I think very interesting. But I think you need to do the circle.
Right.
As care is gone,
Yeah.
and as follow-up, particularly from the Australians, the British, it's very interesting follow-up there. Bigger, if we've had family-centered care over the years since about 2006, where it's on around. This is it. Now this institution, we get notes.
I would have up there 2 years.
Okay, sorry. The
okay,
questions.
yeah, sorry.
And there's.
Don't run away after the one.
Okay. Sorry.
Are there, Lizzie?
These poor parents is what I want to say, because I feel like they're really caught. I mean, it sounds like from your accounting too, they're kind of caught in what the hospital wants to do, and really who cares what they want to do, it sounds like.
It depends on where you are in the country.
Yeah, okay, and also probably if
and
you're in a
also
Catholic
the-
hospital or not in a Catholic hospital, I'm sure maybe
Yep.
that has something to do with it as well. But I feel like at least at the end of life, a surrogate can say, well, I know he would have wanted blah, blah, blah. But you can't really do that when it's a baby, because we don't know what the baby will want. And
So
so,
there are certain conditions
yeah,
where you can say that this baby is going to be devastated. And certainly in the institutions that I've run, I found it critically important to get the parents the best advice at hand for outcome. And then we talk about redirections there from intensive to common. If they turn you down, then at least you're giving them every opportunity.
I mean, look, education for the parents is, I think, key.
Yeah.
But I got the sense from some of this history that you're telling us about
Well-
that, you know, a lot of times the parents weren't getting what they needed from, you know, the providers.
It depended on region as well. That's why I just say
No, I think that's
you
probably-
can't just take, I mean, the story of baby Stenson. I'll tell you a story. If you look at the physician who's referenced, it's Dr. Perlman with my first name, but it wasn't me in that story in Philadelphia. People ask me, were you the doctor involved in that, this compassionate doctor? And no.
Well, anyway, my question was actually, I mean, I went on and on, but my question was about the difference between Catholic hospitals and other hospitals. If you've noticed, you know, like what the, I don't know offhand what the Catholic directives have to say about this, but I'm just wondering
Yep.
how much they push things one way.
Yeah, and I have to admit that I can't answer that question yet. So ask me in 3 years. I'm really sorry.
You're 100% correct. The Catholic hospitals have restrictions
Yeah.
on things as just part of their philosophy.
Go for it.
Can you hear me?
Yeah.
So I'm a retired hematologist. I'm not a pediatrician, not a neonatologist. But over my career, I took care of a lot of patients in the medical ICUs. And it's not exactly the same, but the concept over the decades became what we called shared decision-making. Sort of analogous to what you're talking about, is having the parents sharing the decision. And you know, there'd be a lot of support people helping the family make decisions about people who are on respirators and such. You know, we had social workers and nurses, and of course the doctors and whatever. And there were at times families, for whatever reason, that were totally unreasonable. Their expectations were so unrealistic, one way or the other, either too aggressive or basically hoping the patient would die tomorrow, to be, unburdened by this, or for whatever their motives were. And the thing that really helped sometimes, was having the family doctor or the internist, or even a doctor who was a friend of the family, who they knew and trusted for a long time, come in, find out what the medical situation is, sit down with the spouse or whomever, and the whole thing could be solved that way. It wasn't unusual. Now, I think part of the issue here, and this gentleman who's got a lot of experience in NICUs, is that they're faced with a medical team and a group of doctors who are strangers. And I'm wondering if that happens in the NICU, where, the doctor who's taken care of the family for years, or a friend of the family who happens to be a doctor, can somehow intervene, because as pointed out, these are difficult decisions for many families for all kinds of reasons.
Yeah, I'm not an advocate for outside consultation. I think that we have, and I think you mentioned that, we have a lot of ancillary support systems in the hospital, palliative care team, we've got the chaplain, we've got social work, etc. So when one goes about